will give a talk titled Biomedical Applications of Therapeutic Ultrasound. Welcome.
Thank you very much.
Thank you.
Thank you for attending this class. This is, let's make this as a discussion. And first, we will review the history. Many of you know the sound energy is with us, like some of the fundamental energy that we have with us in the universe, like the photon, gravity, magnet. Sound is one of them. Without sound, we cannot communicate. So, sound is very important for us, but the scientists, like Madame Curie and few other scientists found out later, we can use sound wave for medicine. So one of the purpose in life is to use the sound wave in a non-invasive way to detect the abnormal tissue or abnormality in a very early stage. After that, if we can detect that, sound can also be used in a non-invasive way to remove some of the diseased tissue. So this talk is going to be more focused on therapeutic ultrasound. Okay? Can I advance the slide, or you can advance the slide? You can advance the slide for me? Or okay. No? Oh. Maybe. Is this turned on?
I think it's not working. Maybe we can use now. Yes.
So today we will talk about the development of the high intensity therapeutic ultrasound. It's also known as high intensity focused ultrasound, and we'll go over some of the history.
HIFU is a non-invasive surgery. Patients are released after treatment. We have developed a world-class HIFU product called the Sonablate HIFU that has revolutionized the treatment of prostate cancer. Localized prostate cancer are treated outside. It's called the focal surgery.
So in this seminar or webinar, we will cover the history, some of the other aspects. Most of you know technological and some of the evolution part. So the first paper that was published in 1942 by John Lin identified that ultrasound can be used to produce the focal surgery. So what you see here is the beef being with the ultrasound turned on is treated. And what you see here is created as surgery without causing any effect over here. And that was very instantaneous. So this was the first paper that came out in 1942. Thereafter, these are the pioneers at University of Illinois, William Fry, his brother Frank Fry, and Floyd Dunn, who pursued the research of high-intensity focused ultrasound to primarily study what their effect is on the brain tissue. And what you see here are the most recent pioneers, Dr. Larry Crum and Dr. Gail Terhar, presenting a pioneering award to Professor Frank Fry in 2002 Seattle. So this what builds the whole history now, and we can keep moving. The other gentleman was a very good friend of mine, Dr. Frederick Lidzi at Columbia University and Riverside Research Institute. He was also a pioneer in producing the lesions in the eye. So can I ask you to move, please? May I ask you to move so people can watch you? Yes, thank you. So this was the first device that was built, and it was approved by the FDA for producing the lesion in the eye to reduce the pressure inside the eye. And what you can see here is a very nice instrument with a HIFU instrument here, diagnostic instrument, creating the lesion in the eye itself. So this was a very, very important work that was done by Dr. Lidzi, Dr. Jack Coleman in New York. I can't go back. The breakthrough came in 1980s when a German company named Dornier introduced a extracorporeal shockwave lithotripsy. And you know this slide comes from Oleg. So two X-ray tubes are used to localize the stone, and then use this spark plug, which, when it creates enough current, will generate the shock. And this shock will propagate by this parabolic lens into the kidney stone. So University of Seattle and Indiana University School of Medicine, we performed many, many years of research with Mike Bailey and a few other people in using the extracorporeal shockwave. And Larry suggested it's the cavitation that is what creating this stone breaking up. So that was a pioneering work. And very important of all, that this opened up the medical community saying we can use focused ultrasound for surgical purpose because there is no incision, there is no blood loss. Stone is crushed with several shock waves, and then the particles of stone will pass it out. So this was a very good breakthrough. You can ask me questions, by the way, anytime. So this really gave us the reason at Indiana University to start looking into the project called treatment of prostate also. So Professor Frank Fry and myself at the Indiana University School of Medicine started developing the project called the Sonablate. It is a transrectal device, and we do the intensity modulation to precisely produce the lesions inside the prostate. So this is the slide I developed during the project development. What are the main things we need to do to assure ourselves some success in treating the patient? So we must have to have some sort of an image guidance. For example, in the other case was the X-ray machines, but we can use ultrasound or MRI. We need to know where we are treating. And this is very, very important because we have to know exactly, precisely where to produce the lesion or with the energy to damage the tissue. And when we are damaging the tissue, we need to have some sort of a feedback that allow us to adjust the parameter of the device, and the doctor can adjust those parameters on the site. We should be able to plan this treatment in real time. Means very different than radiation treatment. That means you can plan the treatment by visualizing the organ, and at the same time you can perform the treatment. We must be able to control the energy. So that is very important for this device and this parameter, because every tissue, every human is different. You just cannot use one parameter. So you must be able to adjust the energy. The most beautiful thing of focused ultrasound is different than radiation or other thing, and that is it has no residual effect, because all the other energy mode will create side effects that last for a long time, versus focused ultrasound is instantaneous. You turn off the sound waves and there's no residual effect. So these were the parameters that I use in developing the Sonablate. So these are very simple basic theory that we will talk about a little bit. So one of the major development was done not only by the Fry, but Professor Lele at MIT, Dr. Pond in England, and this curve was developed by us at AIUM committee in 2007 with Kalervo Heinen and myself, Larry Crum, Bill O'Brien, that if you raise the temperature of tissue by X degree, then you have to wait for this long to kill the cell. So this is a very, what we call the biological cell death. So if, for example, if you raise the temperature 18 degrees, each cell will die within 0.1 second. So this tells you, from experimental point of view, there are many contributions here done by other people, that we can control the energy by utilizing the time. Time is very important. That if we can raise the temperature, known temperature, then we can make sure the cell death occurs. And we don't want residual cells, primarily for the cancer patients. So we came up with the transducer. This is real transducer, by the way. It's a therapeutic transducer right here. Right in the middle is a diagnostic transducer. So here is the difference between the two. When you do the diagnostic, you have a transducer with a long focal zone. And when you do the HIFU, you have a very, very sharp focal zone here. So energy produced at the crystal is integrated over here, and you can raise the temperature all the way up to boiling point. So this is done in the prostate. There is no bleeding, there is no cutting. It's very highly precise, and it can be done as an outpatient. The other model we can use is called the PANS model, which gives you the three-dimensional characterization of the transducer, and utilizing some parameters like the density of the tissue, the heat capacity, thermal conductivity, all of these things, you can come up with a calculation that how big the lesion is going to be and what that temperature will look like. So you can get the three-dimensional very ahead of time, knowing your transducer parameters, knowing the organ that you are going to treat in a statistical fashion before starting design of the machine. You need to know what the transducer look like to start with. So this gives us a very nice way to calculate the temperature rise. So you need to know the transducer frequency, you need to know the F number. F number is the ratio between the focal length and the aperture or the diameter of the applicator, and also multiplied by the wavelength. It should be smaller or close to 1 to produce that effect. You need to know the absorption coefficient. Now, absorption coefficient for each tissue is going to be different. And that's been lots of study done. In the literature, you can find the absorption coefficients for muscles, fat, prostate, liver, spleen, things like that. Then you develop the model to produce the peak intensity, watts per centimeter square, and then you control the on-off time to go back to that curve that allow you to estimate the time required to do the cell killing. Okay? So Sonablate primarily works on 3 principles. One, you need to know where you are going to treat. So you take the MR images, or you can take the ultrasound images, you do the fusion with that. Then we are going to do the ablation by producing lesion by lesion in the volume that is identified ahead of time with this. And then we do the analysis, what we call the tissue change monitoring. These are the algorithms that we have developed in our laboratory, and some of that's in public domain already. And we give them 3 different colors. The green color says the temperature is not too high. The yellow color says, yes, you are very close to killing the cells. And then the orange is 100% assurance. The transducer that I will talk about that we developed has this kind of a curved rectangular shape. It has 30 millimeter long and it's 22 millimeter wide, and this is shown in the probe itself. So this was a one innovation called the curved rectangular transducer that will allow you to do both the HIFU as well as do the imaging, and this just shows you in a way where we are focusing inside the prostate transrectally. So the tissue that what we are penetrating is only the rectal wall and not many, many other extracorporeal wise. So that makes life somewhat easier for us for the treatment. We don't have too many layers of tissue to go through in this process. So when the transducer is moving like this, what we call the oscillating, you can produce this nice prostate image called in a transverse direction. If the transducer is moving in a linear fashion, you can produce the image like this called a linear image. Here is the bladder, here is the rectal wall, and this is the prostate itself. So these two in our computer then, these 2 images are always perpendicular to each other. So this gives you the volumetric information during the time of the treatment. So that's very important to keep in mind, that computer keeps track of the position of the transducer at all the time, and the precision of this is a fraction of a millimeter. So this is the way this probe works. You can do the 3-dimensional view of the prostate. So you can see the urethra here, you can see the linear image and the transverse image, and then you can plan your treatment right here, and that will give you the volumetric parameters. You can see these before the treatment as well. Now, some people ask me the question, how do you measure the treatment? So some of this thing, what we call the tissue change monitoring, allows us to do the measurement of the backscattered tissue, and that gives us a robust feedback on energy delivery during the treatment time. So we can adjust that. And this is not 100% temperature, it's a surrogate, means it correlates to the temperature. So tissue really goes through enormous amount of changes during the ultrasound energy sonication. One of the things what we see is the density of the tissue will change. The other thing we see is the sound speed will change. So there has been lots of work, including Ralph Sipe and us, is the tracking of the pixel, because the velocity will change. However, it's a real problem because some of these tissue can have a negative coefficient. Some of them will have a positive coefficient. And because of that, that technique has not worked out very well. Tracking just and correlating that. You can do it in a laboratory, but in a live situation, it's not the best. Increasing the scattering of sound energy in a pulse echo mode, or the total attenuation of sound can be measured. More difficult thing is to measure the tissue expansion. So in our research, what we found is that attenuation will change after you reach 45 degrees in a nice way, linear way, or predictor way, if you can figure it out how to make the attenuation measurement. That paper was published in JASA in 1997 or something like that. So this is one way of seeing that in the muscle, liver, and kidney, they seem to follow very similar trend in terms of energy or the temperature versus the absorption. When we reach to the necrosis level, then at this point in time, the tissue is necrotic and start bubbling, and this is where we stop this linear aspect of this rise of attenuation. The other method that's been, we published that with, by the way, notice Larry Crum was on this grant with us, and Peter Koczkowski. And this is to break down the HIFU cycle in many, many pulses. And then during that breakdown of the pulses, you can take the RF data. So that, in this particular paper, we examine 4 or 5 different methods that gives us the best estimate of the treatment in the dog tissue, in the live. What we noticed here is that this is the focal zone, and before the treatment starts, we collect the RF data, and as the time goes on, you can see the backscatter integral produces larger amount of energy, and this relates to when the tissue is really getting very hot and producing what we call like a popcorn. So we call it a popcorn effect, and you can see there are several things to notice here. One is the velocity has changed. The arrival of the signal is somewhat earlier than the other signals. Other thing is it's blocking most of the energy here, for example. So this is a very good indicator in real time. If you can do this, what the urologists have used this in the clinic all the time, image guidance. So this will produce a large echogenic changes exactly the place where the focal beam is. And it persists for a long time. So you can keep this measuring this or adjusting the power based on this particular measurement.
So the height house is just like a 10 cycle or 20 cycle?
This is sonication started, and then we stopped after 1 second. And this is in microsecond, as you know, 1.5 millimeters per.
Yeah, I mean the explosion signal is 10 cycle or like, I mean the pulse length.
How long?
Yeah, how long is the pulse length?
It
looks like 10 or 20 cycles.
No, much more.
What more?
Yes.
For this one.
You are every 1 second is therapeutic cycle at 4 megahertz.
Oh.
You know,
Yeah.
so you are keeping that for 4 megahertz for 1 second. So many cycles.
Oh.
You know.
Yeah,
So-
then we'll just take
Exactly. So we stopped after 1 second of treatment. For a very short time, we collect the RF data. See, with this transducer in the center, we can do that quickly. And it doesn't take any long time. You just stop the HIFU pulse. And
Between the individual pulse.
exactly. Yeah. So several pulses actually, thousands of pulses. And you can see this, by the way. When you do the scan, right away, you can see the change. So Dr. Wuxing Chen was in my team here, and we published his work in validating this algorithm in the human with Dr. Uchida. And the primarily, these are simple method of showing here is you're going to do the FFT. This is pretty rigorous way of doing it. Really, you don't need to do lots of calculation. You can do this real time. And after 1 second or 2 seconds or 3 seconds, you are going to collect the RF data coming back. Just don't take one point. You have to take several points. And then you need to average. All of those things needs to be done properly so you can calculate some of these parameters. So statistically derive this number rather than a single point. Single point will mislead you. So here is an example of before the treatment signal, and here is after 3 seconds. And you can see the energy in the spectra of pre and post HIFU. And you can see very clearly a big difference as a function of frequency. So we make these measurements and then we analyze everything in the frequency domain. And here's the correlation between our measurement of change in energy, backscattered energy, versus temperature. The temperature is measured with a very, very tiny thermocouple. The size of the thermocouple is generally speaking in micromillimeters, so that it does not give you the distorted signal. And there's a very good cross correlation here of the temperature measurement and the energy change. So during this treatment time, what we are really showing is the prostate is here, and we are going to be treating from the apex of the prostate, what we call it right here, going toward the bladder of the prostate. And every time you treat, the RF signal analysis will produce this kind of a indication going back and looking up into the computer. The computer will produce this indication, and if it's orange, it will show overlay that this treatment is going very well. If it does not produce that kind of a signal, you can adjust the energy so that you can make sure the tissue is getting the amount of energy needed at that particular location to kill. Now, each site here is separated by 3 millimeters, for example. Same thing here. And so the whole line of the prostate is treated. Then you move the transducer in a transverse direction at an angle and do the same treatment again to treat the entire prostate. So here is the map of first treatment and second treatment. In some cases, like this green, was removed by retreating that same volume, or these greens are removed. So you have a chance to go back and retreat the same tissue again right away, not wait for too long. The reason sometimes you have to do it is because the beam was diffracted by some other means, or what we call the microbubbles inside the prostate. By the way, speaking of microbubble, if you are not careful, the prostate, the ultrasound will create the inertial cavitation, create the microbubbles. These microbubbles can start circulating within the prostate gland, and it can restrict the energy delivery to the targeted site. So you have to make sure the microbubbles are not there or wait for the microbubble to go away. So that's how you can improve the treatment. So here is the cancer localized by MRI. Dr. Mark Emberton at Imperial College, he treated using what we call the visually directed high-intensity focused ultrasound. And after the treatment, same prostate, what you see here is entirely necrotic tissue. No cell is alive within that. So you can get a very good measurement where the treatment is taking place. So overall survival rates over many years with using the HIFU is close to 97.7%, and cancer-specific survival rate is 99.8%, published by Dr. Uchida in the Journal of Urology using HIFU. So we have a very good outcome. The new development going on for the last 10 years is use the MRI to detect the localized lesion and only don't treat the entire prostate, but just treat only the lesion like this. And that way, the treatment is faster, treatment is safer, things like that. So here is, again, the lesion is located here. MRI and ultrasound is done the fusion of these two. That's in our device now, commercially available. And then when you do the treatment, this is what I was talking about, the popcorn. And very nicely you can see this. And only half the prostate is treated here, and other half is not treated, as you can see here. It's called the focal therapy now. And you can, now what is happening with the advanced MRI, you can find the lesions in a very small size. So you don't need to treat the half of that prostate. You can treat only quarter of the prostate. So the other method we are developing is utilizing Larry Crumb's bubble here. Is the cavitation bubbles. And what you see here, watch this. You see how rapidly it's producing the particles in a chalk here. And you can erode this hole and very nicely using the cavitation and bubbles here. So here is the method in which you can see all the time good feedback where the treatment is taking place and follow up with MRI. This is for the treatment of BPH, where the benign prostatic hyperplasia, where the man has a very large prostate and he has the symptoms of problem of voiding the urine. So this is the treatment for that. Now, we are also looking at different applications using the same platform for what we call the laparoscopic approach for kidney cancer, rectal cancer, things like that. And we call that a sonosurgery, and the name of the treatment is called sonotherm. Here is the probe showing you the focal zone, very sharply focused. The transducer is fairly small, and you can create a volumetric lesion like this by moving the transducer back and forth. So this is another product that has been used and tested in both England as well as in Austria. And what you see here is a lesion produced inside the kidney under the guidance of this probe called sonotherm. Now this is my exciting time to show you some of the early results of utilizing the pulse focused ultrasound or the low energy ultrasound in combination with stem cell. So patients, what we call the peripheral artery disease, have their artery inside their leg blocks the blood vessel like this because they have this plaque or a complete shunting. And these patients are mostly diabetic and they have a walking problem. And how do you help them? So it's several different ways. The approach is, one of the approach is to use their own stem cell, utilize the focused ultrasound, guide the stem cell at the site where you know it needs to do the revascularization. Can I go on? Okay. So we did some study using the stem cell and a randomized study where LOFU and stem cell were used versus stem cell only. It's not a huge study, but at least this is a preliminary study to show you that when we use 50 pulses of LOFU at a given site at 1 megahertz frequency, we might be able to produce some effect. So here you go. You have a vascular ultrasound, and you bring the patient here. Here is the problem. And what you want to really know is, can you treat this kind of a patient? And you can use the LOFU device here and provide these pulses of 25 millisecond on, 225 millisecond off. This energy delivery is so benign, patient does not feel anything. And you can do this many, many times actually. And the site will produce the signal called the danger signal, and that gives the stem cell to attract at that particular position and start reworking on that and produce revascularization or cleaning up the mess that what we call it in the body. So this is a very early on. I gave this talk at IEEE 2-3 years back, and we have very good data from a perspective of it's safe, it didn't hurt anybody, and we can do a large-scale clinical trial to see the value of low-energy focused ultrasound. And it's very easy to do. So this is one of the project, my favorite project besides the prostate. So just to give you the preview of this, that both the groups of the patient did very well, and that's where we are right now. So we have now come to China with our partners. We are working with them, and this is the exciting place to work with. This is our company, people in Indianapolis working together, and thank you for this opportunity to share my story with you. There is a slide of Ralph's site. Somebody asked me. Unfortunately, I don't have it in this one. It's in my deck. I will send it to you. Ralph is the one guy, and I've been working together since 90s, and we have done lots of work. My point is very simple. Making measurement with ultrasound is very, very important. We should continue to do the research on that as much as possible and investigate many other areas possible for providing non-invasive treatment to the patients. Thank you again.
Thank you, Bestie.
Yes, sir.
Thank you for the presentation, Professor Naren. My English is poor. I want to ask a question about the ultrasound treatment. Is there any any reflection between the supersound and the stones? If there is a stone in my body and I'm doing the supersound treatment, is there any reflection between the supersound and the stone?
Can you somebody repeat that question for me?
He's asking that if there is a stone during the treatment.
Oh, stone.
Yes, stone.
Is there any reflection?
Reflection.
Yes. That's, remember my first slide on a kidney stone? We use for the kidney stone called extracorporeal lithotripsy. So if there is stone, we have to find a way to get around it.
And as you said, each person we're using the different energy. Like an old man, maybe less. How can you differ the difference?
That's a good point. The old man or the young man, we have a different organ system, right? So their blood vessels are going to be different, etc., right? So we have to adjust the power level based on how the tissue is reacting. So let's go back. Okay?
And I have an idea. If you can, using the reflection, then you can see the energy will be useful in the same time. Have you tried? Okay.
Yes, that's that. I think you didn't get that point maybe. That point is right here. This is the reflection coming from the tissue. So if there was a stone, you would get a very large reflection. You see? So this is the slide. And for a different people, you will have to adjust the power level so that you can produce this kind of a, where is that? This map tells you, I'm sorry, my hand is not as steady. This color gives you, the doctor, the idea where you have to apply more energy or retreat the same thing. So this is, for example, did not get enough energy in there. Second treatment at the same site, get rid of the yellow into orange.
All right. Thank you for your patience.
Okay, no problem.
Any question?
Yes, sir.
Thank you for presentation. When temperature elevation of tissue, especially reaches about 40-45 centigrades occurs, biological tissue might experience irreversible necrosis. This will link parameters connected to temperature changing sharply. And my question is, how to overcome this obstacle to realize quantitative temperature estimation?
Oops. So this is the curve, what you are talking about. Very important curve, done by many other good scientists, right? So what it tells us is that if we want to provide an accurate amount of energy, we need to have some time, treatment time, if you know what temperature we are going to reach. We have to calculate the temperature based on a theoretical model. I thought I have it somewhere here. Wow. So you need to know the intensity. You need to know some of these parameters to start out with. So it takes experiments to really know what the tissue is going to look like. So it's a statistical approach that we have to take in order to reach to that energy level. So what happens in the prostate, for example, we start out with 1600 watts per centimeter square. And because we know what our transducer look like, okay? So we can calculate based on our transducer.
If you mean the temperature estimation will use the theoretical model to predict the evacuation.
Well, I mean, one way to see is the temperature, okay? But there are other means too, and that is the echogenic changes.
How much is the accuracy?
Very, very accurate. Because when you do the histology of this tissue, it's only that area getting ablated. So this tells you, first of all, this tells you very accurately all the energy remains within the prostate itself. Nowhere else is being going out, you see. So it's very nice, very accurate within few millimeters here, you see. The other is the long-term data. You have a 99.8% of the patient survived after this treatment. That means all their prostate cancer was killed.
Can we reach the accuracy below 1 centigrade?
I personally don't think you need to worry about 0.1 degree. There's no need to worry about that. If you are going to kill the tissue, why are you worrying about 0.1 degree? What's the reason? I mean, tell me, what's the reason? Why do you have to worry about it if you are going to kill that tissue?
I mean, if we measure temperature more accurately.
So first of all, this is not a hyperthermia. We are not doing hyperthermia. We are ablating the tissue. So we have to have some fundamental understanding of what is your aim, what's your goal, okay? And we are not after one cell at this point in time because we have no way to diagnose a cell which is a tumor cell. So you have to treat. Right now, what the doctors will do is treat the whole area. And because it can spread in another area as well, so it's called the margin of treatment.
You mean when temperature evaluates over 45 centigrade, the centigrade doesn't matter, and it always concerns the necrosis area.
Yeah. So number one is we have to reach about 65 degrees, not 45 degrees in the ablation.
Yeah.
If we are going to ablate the tissue, we want to do it very fast because if you just reach 45 degrees, you have to wait for hours to treat the whole organ. Nobody is going to be interested in this. So we first and foremost, we need to treat very fast. That means you have to raise the temperature very quickly above 65 degrees. Once you reach that, then you move to the next site and the next site quickly. So our aim has to be how is going to work in the medicine. So that is our theoretical approach. Some of this comes from pharmaceutical. When the drug is delivered, every person is different, so that's what you have to have a drug dosage, a statistical way of proving it.
Okay, thank you for your opinion.
Thank you.
Okay, the next question. Yeah, I have a question.
Sure.
For the high and the leaf, high and LIFU leaf, what's the temperature peak difference in the prostate?
In the
stage?
mm-hmm.
If we use the high or leaf.
Oh, Heart and liver,
Yeah.
very different.
What's temperature?
Yeah.
difference?
Here, the problem with the heart and the liver is called the heat sink. So when we go to simulate this parameter, you are going to have a different heat capacity for that organ. For a heart, it's going to be different, and perfusion is another parameter going to be very different. So what we do in prostate is not necessarily going to work for liver, and it's not what works in liver is not necessarily going to work for heart. So it is a challenge for us to develop specific models for specific organ.
So when you treat liver tissues, you use hive, but if you treat prostate tissue, you use leaf.
We don't treat liver, so we are only treating the prostate. I would not recommend this probe for liver because everything will change. Thank you again.
Thank you.
I wanted to thank both of you for giving me this opportunity to present with all the young people here. They are the energy of our future.
You are welcome.
Thank you.